Hey, what's up, world? I love it. I love it on Thursday nights when we meet with the great Dr. William Bridge. How
Hey,
you doing, William?
good to see you again.
Good to see you, man. How you feeling today, dude?
Feeling well. Glad tomorrow's Friday, but it's always nice capping off the week with one of the podcasts. I've enjoyed it, and I'm looking forward to tonight.
Awesome. You were able to listen to some trance music today, you said?
Yeah, I was this morning.
Uh,
Would you listen to anything good?
I just put trance mixes while I work out. I'm
Yeah,
assuming you do the same, or you.
yeah, and it's early, before the sun's up. It's hard to imagine a different type of music to listen to get you. But
Yeah,
uh,
well, man, I really, William, I really appreciate you taking time off, and I know you have a busy schedule, and so do I, and we may take time to share knowledge with the world out there. And hello, world again. And today we're going to be talking about eating disorders. And William, what's your experience with eating disorders?
Well, I would say, from my perspective is, the patients that I've had in the inpatient hospital setting is, usually they present with a different reason behind their, ideas behind the admission, meaning that, they came in with a depressed mood or, thoughts of wondering what it would be like not to be here anymore or uncontrolled panic. And then once you kind of develop the clinical rapport with them, so to speak, that things kind of surface and you find out that, maybe a lot of the depressed mood or, a lot of the anxiety is a result of, self-image and, sometimes it's tied to occupation, where you have somebody that's in, I've had competitive ballerinas that are in these, various ballet companies that have to maintain a certain weight. So the anxiety is very high, and the importance of the appearance is very high as well. Jockeys or bodybuilders, jockeys, of course, being on the side of having to maintain a low weight, to race horses so that they're not slowing down the track time, is another variation that I've seen. Of course, some of the issues to, the desire to have more muscle mass, and I know we're going to touch in to some of this. So, that's been my experience, is that in short, it presents like one scenario and you find out that there's something else going on. So what about you? What have you seen from the eating disorder?
It's so interesting that you mentioned that, William, because a lot of times from my experience is that the symptoms are masked, and if they can really go unnoticed unless you really pay attention. And sometimes, like you said, the client, part of the anxiety they may be feeling in the initial assessment or the initial intake, um, if we don't notice the symptoms involved, then the eating disorder will be masked. So just for the audience to know, an eating disorder is a serious mental health condition, and it holds no barriers to race, ethnicity. It can be, when it affects someone or when someone is experiencing the symptoms of an eating disorder, it can be really fatal. And that's what we're here to talk about today, to raise awareness about eating disorders and how fatal it can be. And so, who may be affected by eating disorders? Anyone. And they can be found in both sexes, all age groups, and across a wide variety of races and ethnic backgrounds around the globe. So it's not just concentrated in Western culture, in Europe and Africa. It's across the world. And I think you said it best, William, when you say that it depends on the occupation sometimes that the person has, because that involves a higher stress to meet certain um, body image or the curves or whatever the case is, or even for men. And that's a common misconception. And there's a stigma behind that men don't suffer from eating disorder or don't suffer from the symptoms of an eating disorder as much as females, but that's not necessarily true. All someone has to do is go inside the gym and see it for themselves. So let's talk about, before we get into the actual definitions involved in eating disorders, such as the types of diagnosis potentials that there are, William, let's talk about how common eating disorders are. Do you mind if I read you a couple statistics?
Yeah, I'd like to hear it. I'd like to hear it, especially if you have anything regarding, sex in the male versus the female. And, I know one thing that I've read is that, the gap in how many, used to be 95% female at one point and, less than 5% male, that type of situation. I know that gap has been narrowed. So I'd definitely like to hear some of the stats you have here.
Oh, thanks, William. So let's start off with the first one. For women aged 15 to 24, eating disorders are among the top 4 leading causes of burden of disease in terms of years of life lost through death or disability. So eating disorders, I got these statistics, by the way, from the National Institute of Eating Disorders. I didn't know they existed until I prepared for this podcast, William. Can you believe that? And it's telling us here that it's a top 4 leading cause of burden of disease in terms of years of life lost through death or disability. So an eating disorder can be fatal, is basically what that statistic is saying, not only in longevity, but in impairments that can be developed.
Yeah, absolutely. And I think some of the danger, becomes, depending on what disorder we're deciphering, but severe electrolyte imbalances, whether it's from, chronic history of, self-induced vomiting. You can have, fatal arrhythmias as a result of electrolyte imbalances and, multiple chemistry abnormalities that can arise from it. I think that's another thing, is that the danger of a lot of this is under the radar, but, kind of having to keep in mind that, normal nutrition or adequate intake is considered a lifeline. It would be like, it's not as drastic, but you can imagine a scenario where, there was a pathology where somebody didn't want to breathe, right? Or didn't want to drink water, because this is, kind of what we're up against here. But I'd like to hear a few more of the statistics if you have them there.
And thanks, William. And when we're talking about, you mentioned earlier about suicide, and that's a very serious topic, obviously. And anorexia nervosa has one of the highest overall mortality rates and the highest suicide rate of any psychiatric disorder. The risk of death is 3 times higher than in depression, schizophrenia, or alcoholism, and 12 times higher than in the general population. So, William, you and I, we've collaborated on podcasts when it comes to depression, and we talked about the suicide rate then. I don't remember what the statistics were, but I remember we talked about them because we read a few of the stats and the data involved. And this is saying that those that are struggling with the symptoms of an eating disorder have 3 times higher chance than those struggling with depression of attempting a suicide. And when we talk about that, that's very intense. We even did a podcast on substance use. We touched on alcoholism. There, I don't think we talked about the suicide rates, but here it's saying it's 3 times higher than those suffering from the symptoms of alcoholism. When we're talking about suicide, I'm so sorry. When I just want to add one thing. When we're talking about suicide, that's a dangerous game we're playing. That's someone's life, and at that moment, their way of thinking is very real to them. What they're feeling is very real. Of course, that's why they might engage in the act or attempt it. But really, the perspective and the way of thinking, it's not necessarily true. It's something that they created about their body image, the curves. It's not good enough. It's not big enough. They're not skinny enough, et cetera, et cetera.
Yeah, I think just kind of elaborating on, just to refresh the listeners about some of the stats we had touched on. So when you look at the, lifetime prevalence, so let's just say, you have, your average age individual over the lifetime, we're looking at, some say as high as 17%. for patients that will have depression and will subsequently go on to complete suicide or, terminate their own life. Now, so if you take that number, and what you're saying is if you take the, population of patients that have had a psychiatric diagnosis of anorexia nervosa, we're talking about, suicide in, somewhere around the 50th percentile. So it's unclear, whether or not that is suicide that is as a result of a self-inflicted injury that was independent of the lack of nutrition, or was it, the lack of nutrition itself that eventually led to death. So very, very serious disease, I think, is the takeaway point. And, like we always remind listeners, if there's anybody or, you're having your own thoughts about self-harm or anything, the best thing to do is contact your primary care physician or 911 or go to your closest emergency room.
And that's so true, guys. Dr. William Bridge hit it right on point. Okay. So William, we can talk about the effects of eating disorders, statistically, how it affects not only on the individual level, but on a systemic level for society at large. We can go a bunch of different avenues, but I think for the listeners' sake, we've teased them enough, and I'm going to give them the definition by the APA. So, guys, we don't just make up statistics here and stuff. We always try and cite where it's coming from, reliable source. And I think the American Psychological Association is the powerhouse for psychology in general. So, and I'm sorry about that, William. And when it comes to the American Psychiatric Association, I have a lot of respect for them too. But, considering the fact, I'm just going to quote what they say here. Eating disorders are illnesses in which the people experience severe disturbances in their eating behaviors and related thoughts and emotions. People with eating disorders typically become preoccupied with food and their body weight. And it's, I'm just going to add to that for a second. It's not just their body weight in specific. It's how the body looks. So the weight is just almost like a consequence to worrying about the weight's almost to a consequence to how it's actually looking. Do they look like this model? Do they look like their idol? Do they look like, the basketball player that they're following or whatnot? And that's important to understand because eating disorders affect several million people at any given time all around the world. So the three main types of eating disorders are anorexia nervosa, bulimia nervosa, and binge eating disorder. We're going to touch on each one in specific, William, but what do you think about that definition that I just said, that I just read, from the American Psychological Association when it comes to eating disorders?
I thought it was really solid, and I like it because it covers, each realm of what an eating disorder can, stem from without over including, too many people. For instance, a patient that wakes up and has a midnight snack, 5 days a week. That's not what we're talking about here. So the definition is, includes enough of the avenues where eating disorder can become or can originate from without over including, people with good appetite. So I like that a lot.
And in my experience, William, when some of the symptoms of an eating disorder, they can be masked, and we talked about that in the beginning. But those that are struggling with the symptoms in general have behaviors and attitudes that indicate that weight loss is necessary, dieting is necessary, and in consequence, and this is something I've seen, even though my experience in the field has been limited when it comes to eating disorders because I'm a substance abuse counselor first and work on mental health secondary, but there are consequences to when someone, or signs when someone's struggling with an eating disorder, and I'm just going to point out a few of them. Sometimes dental issues, but another big one, and this one's not observable. These are consequences on an individual level. It's almost systemically financial problems. And I don't want to call them problems, but if someone starts struggling with their weight and they're constantly worrying about how much they weigh, how much they look, with new, and they're not eating enough, or they're purging what they're eating, and they're constantly preoccupied with thinking about how they look, if they look good enough, that's going to affect their work. That's going to affect if they even want to go to work, because now all of a sudden they become very anxious that they don't even look good enough in society. And they turn into, and if you lose your job, all of a sudden you don't have money to pay your bills. That's a big issue there. And that's something that we need to talk about, because, William, it's not just about the individual, oh, that individual, and now that individual struggling with an eating disorder. That's not my problem. Yes, it is. Because all of a sudden that individual that's struggling with the symptoms of an eating disorder, I'm just going to throw out anorexia nervosa, they can't work, they can't be a productive citizen in society, and they go, and now they need help from the government, from the taxpayers' money. So it does affect a person systemically, as much as the individual level. And when and what do you have to say about, or what are your thoughts on that, William? Because a lot of times when we talk about mental health and mental illnesses, people only think about the individual. And so sometimes, oh, that's not my problem because I'm not struggling with it, but they don't see it as a whole. They're missing the bigger picture
Mhm.
of society at large, and different societies, and as we start getting more global.
Yeah, and I just wanted to just kind of touch on and add a couple of things to what you said about, it's only so often where, we have, a mental health ailment that then subsequently transitions over to physical symptoms, So I think that's, what we had talked about in the past is that's been a lot of the challenges with mental health and behavioral medicine and so on, and that, we don't have that physical symptoms, but in, these eating disorders, you had mentioned the kind of the dental erosion or enamel erosion that leads to poor dentition. So, of course, this is from, increased frequency of vomiting, where you have the acid wash up from the stomach, and over again can lead to a breakdown of your enamel and tooth decay. The flip side of that is if you are not having adequate nutrition and you have very low vitamin C, so you can have gum ailments and even severe scurvy, gingivitis, like from severe vitamin C deficiency type of thing. So I've seen that before. And another physical thing that you can look out for, they've actually given it a name. It's called Russell's sign. And the Russell sign is scarring on the back of the hands from when the fingers are used to induce vomiting. And when you go to vomit, the teeth on the top jaw hit the back of the hand. So you'll see that in some of the severe purging cases, Russell's sign. So, very, very serious, physical ailments to go along with a very, very serious psychological pathology.
Well, I'm going to mention, I was debating on whether we should mention the symptoms or the signs of an eating disorder, or if we should go along with mention some of the signs as we talk about the specific diagnostic criteria for certain diagnoses. You think we should go along talking about the diagnosis and we'll mention signs and symptoms as we go on?
Yeah, I think that kind of keeps it categorically organized for the listeners. That way you can kind of have an association with a given disorder.
Okay, and I agree, and man, I'm so glad you're here, because you get to you with you, William. We don't just touch the surface; we actually get into detail from a doctor's point of view, man. So I really appreciate it. Okay.
Yeah.
So let's talk about the I don't want to say the most famous one, because that's not cool, but definitely the one that I hear the name the most, which is anorexic nervosa.
Mhm.
There are two ways, there are two types and listed in the DSM. So there's the restricting type and the binge eating type / purging people, people out there listening. So the restricting type, anorexic anorexic nervosa, immediately when people think of that term, they're thinking of someone that's struggling with not weight loss, but they're definitely too small, or they don't weigh enough. They're concerned about their body. They seem very skinny, and sometimes this can be hidden because someone can wear baggy clothes, someone can hide, whether if they're struggling with the symptoms. And the restricting type, let's go with the first type, the restricting type, William. And the restricting type is someone who's constantly preoccupied with how they look. They're constantly preoccupied in how much they're eating, what they're eating, and they really, really limit their options as far as what they're going to intake and what they're not going to intake. And that's been my experience with anorexic nervosa. I'm trying to look in my notes to see what specifically I wrote, and here we go. Dramatic weight loss, dresses in layers to hide weight loss or stay warm, because now that since they're skinnier, they don't have as much fat to cover themselves, so they tend to be cold a little easier. Preoccupation with weight with food, weight, calories, fat grams, and dieting. Makes frequent comments about feeling fat despite obviously noticing that they're not. Resist or is unable to maintain a body weight appropriate for their age, height, and build. And that's what I got for anorexic nervosa. I don't know if you want to add to that, William, but can you talk a little bit about the restricting type? Because we're going to talk later about the binge eating / purging type and how it differentiates from bulimic nervosa. But let's focus on the restricting type.
Yeah, and I think just to emphasize what you said there, because there's a lot of good information, but keep in mind that the result of the pathology is a reduction in weight. So you take like a body mass index, the ideal body weight. These patients, no matter the type, either the restricting type or the binge eating type, or purging that we'll talk about in a minute, the body weight is below what would be considered ideal or normal for that. So that is a huge, points when it comes to these diagnoses. So when I think of the restricting type, so of course you have under ideal body weight or lower than normal body weight. And I always ask myself, well, how was this accomplished? And usually it is brought back to something along the lines where it's either through dieting, that's where you get the restrictive name. So their caloric daily intake is limited, let's say to 400 calories a day would be a specific example. So fasting, this has been a huge thing in the media lately, this intermittent fasting. So I've seen a lot of sick patients on the medicine floors from this. So, I think there's a lot of, positive that can be said about it, but, a lot of this is being done from what's read on the internet, and it's leading to a lot of bad things. So, fasting, so we're talking about no food intake for certain, sometimes 2-3 days stretches, which can get pretty dangerous. And then the one that I think is missed the most is excessive exercising. So these are the patients that are doing 2.5, 3 hours of cardio a day, going to the gym 2 and 3 times a day, weighing themselves multiple times a day. So these are some of the these are real clinical type of examples I've heard in the past. So I think that's kind of emphasized a little bit about what that word restricting when it comes to classifying anorexia really means.
And man, William, that's such great information, and thank you for bringing that up. By the way, people out there, what William was talking about was for anorexia nervosa, there's a severity rating. I think they split it up into 4 categories, and it's based on body mass index. So I'm guessing, William, the lesser the number or the lesser the percentage, the higher they are on the scale. Is that right?
Yeah, so I kind of, if you think of, body mass index, you can say what you want about BMI, but basically the 4 variations that I think you were touching on is either mild, moderate, severe, extreme. So mild would be just below the acceptable adult BMI, which is 18. So anything less than that, if you think, 17 to 18 is mild. And then as you go further away from that normal, so like 16 to 17 BMI is moderate, 15 to 16 is severe, and then extreme is anything less than 15. Of course, that's BMI in the setting of the other diagnostic criteria. It's not just BMI alone. Some people are very low BMI because they have malabsorption disorders and they can't gain weight. That's not what we're talking about here. This is, somebody that has that type of restrictive behavior in addition to a lower BMI.
I don't want to start making. I want to be careful and not saying something and people taking it as causational statement. Mm-hmm. But I remember learning in school, because I'm fresh out of school, about 6-7 months ago with my master's, it's that with anorexia, the restricting type, there comes a certain personality, like a certain perfectionist type of attitude or personality that someone has that tends to be correlated. I remember I wish I would have had that article. I wish I would have stated it what the professor handed out. That's correlated with the diagnosis. But since I don't have it, I don't want to get too much into it. Sure. But when it comes, and now we're gonna switch this a little bit, and talk about the fasting that you were mentioning, William, because that's something that I actually had thought about bringing up on this podcast and I had forgotten. And when it comes to fasting, I have a friend who fasts, and he seems to, his body has paid off with it, although he varies his fasting. So some days he'll intake food for 3 hours. There's a 3-hour window, and then he'll close it. But in those 3 hours, he'll consume, the most he can. And maybe I should have saved that for the binge eating portion, because to me it can be kind of cloudy and what we fit in. But when it comes to anorexia, the restricting type, what have you seen in the hospital when it comes to fasting? Are people trying to intake the most they can in a 1-hour window and then they won't eat for 23? Or because you mentioned multiple days, and that's something that's very dangerous, someone not eating for multiple days.
Yeah, so a few of the things that I have seen, presentations, I've seen it more along the realm of such a restrictive behavior that it leads to like a syncope or, of course, the passing out. So they're, kind of orthostatic or lightheaded because they don't have enough volume in their vasculature. So, their tank is low because they're not drinking, not eating, etc. So I've seen that once or twice. But I've also seen it a few of the times where you go into what we call, this is a lot of fancy terminology that I'm trying to stay away from, but like almost like a metabolic, lactic acidosis, where your body is waiting for those calories that you usually take in through food, and you are not taking them in. So what does it do? The body kind of turns to, the muscle. So it starts breaking down different parts of the body to then kind of get energy that way. So very severe, and of course there's different religions where the fasting is part of the religious beliefs. And Most of the religious-based fasting, when it comes up and gathering a history from a patient, I've never seen that become a problem. It's definitely takes discipline, and I give people a lot of credit, whether it's for dieting reasons or intentions of trying to acquire some sort of physical gain out of the intermittent fasting. Takes serious discipline, but like we say with everything, it needs to be done with caution, which is, I think, the point here.
Thank you for clearing that up, William. So we were talking about that there's two types of anorexia nervosa. There's the restricting type and the binge eating / purging type. And so sometimes someone thinks that the binge eating / purging, that's not the criteria for anorexic nervosa. That's the criteria for bulimic nervosa. And so let's talk about the binge eating / purging, and we'll incorporate bulimic a little bit, and we'll explain the difference. So there's two types, although I don't want to use the word type because Mr. William corrected me earlier for that. But there's two types of anorexia nervosa: restricting type and the binge eating / purging type. With the binge eating / purging type, someone is binge eating, and then all of a sudden, right after they're purging it, they're sticking their hand inside their mouth or whatever it is, and they're vomiting it. That's the same criteria for bulimic nervosa, except one key component. The reason why they have the binge eating / purging type under anorexia nervosa is because if someone is binge eating and purging and they're still, their body mass index, like William, you explained earlier, is very, very, very low, then that means they fit the criteria for the binge eating / purging. But with bulimic nervosa, it's a little different. If someone's binge eating and purging and they're either at a normal, or no, not normal, but a typical body mass index, or they're overweight, then they may meet the criteria for bulimic nervosa. But a key component for everybody to understand is, and I hope I'm not getting too technical with the terms, is that the severity rating for bulimic nervosa is based on compulsory behaviors rather than body mass index. And William, I hope, did I miss, maybe I didn't make it clear enough for the audience, or I know maybe you understood, but do you think the audience understood what the difference between binge eating / purging under the anorexic nervosa umbrella and the bulimic nervosa umbrella, the difference between both of them?
Yeah. And I think that, just kind of touching on, just adding to what you said, is that when you're talking about, so the category anorexia nervosa, the specifier, the binge eating / purging type. So, we talk in a sense that during the last 3 months, the individual has engaged in recurrent episodes of, and remember, it's binge eating, which is the in, right? So a certain amount of food in a short amount of time. But then there's the / purging. And remember, this can be, the purging can happen in more than one way, just kind of adding on to, what you had said about the vomiting, which is the most common one. But keep in mind that sometimes it's misuse of laxatives is a common thing that I've seen. So, you have patients that are taking over-the-counter laxatives, stool softeners, to kind of induce, diarrhea and kind of, speed the guts movement to kind of get food through them before they have time to absorb the nutrients. So that is one way. And the other couple that come to mind are diuretics or water pills. So you're taking these blood pressure or fluid regulation pills and actually keeping the free water in the body very low, so you lose weight that way. And the last thing is enemas, which can be kind of along the realm of laxative type of abuse. So that I just wanted to elaborate a little bit on what that purging behavior can be consistent of. Is there anything else you wanted me to speak on regarding bulimia? like
Oh,
as a separate diagnosis?
well, yeah. If you have, because I will admit to the audience that, I have my master's in mental health and everything, and I'm a prevention therapist, but my knowledge and my um, competency when it comes to eating disorders is somewhat limited as far as in a clinical setting. So if you have anything to add, be my guest. But I can only imagine, William, the gastrointestinal implications or maybe the development of osteoporosis when it comes to binge eating and purging, because the stomach, it's not how it was evolutionary. That's not how it's really supposed to operate. And
Yeah,
so,
absolutely.
but yeah, when the difference between binge eating slash purging and bulimic nervosa, it's very minor, just a different severity rating scale, and body mass index varies as well. But William, we're cutting a little short on time, so I want to keep moving on if you don't mind. And there's
Yeah, no,
two
that
more,
sounds good.
yeah, there's two more diagnoses and specific that I wanted to get to touch on, and we can even talk about other things as it goes on. But
Sure.
the next one I wanted to talk about was um, body dysphoric disorder, and I learned about this, William, in 2013, or excuse me, the end of 2012. It was termed, I think, in the DSM-4, if I'm not mistaken, because at that time the DSM-5 hadn't presented itself as reverse anorexia. But now it's more body dysmorphic disorder with muscle dysmorphia.
That's
Uh,
right.
and this one is one that doesn't get talked about. I don't have any statistics on me at the moment, but this one I would imagine that males and females, maybe the population that meets the symptoms for this may be equal, but society tends to view men as it's okay to want to have muscles. It's okay to be so preoccupied with your diet and your workout regimen that you want to look big, but men need help too. And when I go to the gym, I don't see as much now, but if I were to step in, let's say, Gold's Gym, I see a lot of men that are constantly looking in the mirror, constantly preoccupied with how they look, the diets they're taking, what they're implementing into their bodies, and they're weighing themselves every day. It's almost like they meet the criteria for with muscle dysmorphia, but it's not talked about. They're not aware of it, and it's something typical in society. Has there been any experience going into the hospital? And I'm going to be biased about, like, my biases, and immediately think and assume no, but has there been anybody that comes in for help, looking for help, struggling with muscle dysmorphia as a man?
You know what? I've so usually when we talk about the inpatient setting, I've seen this more in an outpatient setting, so in the clinic, and a few of the times that I've had it surface in practice would be, somebody that comes in maybe for mood disorders such as depression, and you maybe notice, large muscle mass, skin changes, or acne scarring, that type of thing. And you come to find out that there's like a anabolic steroid abuse. Maybe a few times I would say that that decision to begin using injectable anabolic steroids kind of stems from a body dysmorphic disorder. The other thing that I would say is that, something that would put it on my radar in a clinical, situation would be somebody that has had multiple plastic surgery interventions, whether it's, and we're not talking about, the Botox every 6 to 8 weeks, in the few places in the face. We're talking about 4 or 5 different rhinoplasties or nose surgeries, chin implant, breast implants, multiple areas of surgical intervention kind of should heighten clinical providers' awareness about the possibility of a dysmorphic disorder.
Dude, I'm so glad you're here because you know what? It's not that I wasn't aware, but it's always good to bring it into consciousness sometimes because I can only speak for myself, but I forget. But that's so true when it comes about the plastic surgery because I'm only thinking about diet and the way they look as far as building muscle and the abs and constantly getting a marker and seeing where they need to improve and stuff. But you're
Yeah.
really touching upon the surgical part of the physical part. Um, but males accounted for roughly 10% of anorexia nervosa and bulimia nervosa eating disorders. This study was done in 2013, but males suffering from eating disorders and body image issues, they have an immense stigma to overcome, and as a result, have been significantly neglected in both diagnosis and treatment. And part of that is because clinicians that treat males with eating disorders are very challenged. The resources are limited, and it's only now where the stigma is being talked about. So when we're talking about body dysmorphic or muscle dysmorphia, this is something that hopefully just this conversation can bring more talk on the subject because it's something that really needs to be addressed, and males are the ones stigmatized by it. It's a huge stigma they have to overcome. But this is starting to change a little bit, thank goodness. And as we do more research, hopefully this can shed light on the issue. But treatment's limited. CBT is a great form of treatment for all the other eating disorders, but for muscle dysmorphia, there's not much research to even show that CBT is a proper form of treatment.
Yeah, I think I'm glad you said that about treatment. So, for the first 2 things that we, really spent a lot of time on tonight, that being anorexia nervosa and now body dysmorphic disorder, the studies have actually showed that medications do not help. So I'm not saying that, one drug's better than the other. What they've proven is that you give somebody, something like an SSRI, such as Zoloft, Prozac, and you compare that to giving them a sugar pill or a placebo, there was no difference. So this treatment approach for AN, anorexia nervosa, and body dysmorphic disorder is definitely a therapy or, a behavioral therapy approach. But even then, it's refractory to therapy, very, very, we're talking about long-standing chronic course of therapy. And it's only bulimia nervosa that SSRIs or medications show to help in addition to therapy. So kind of a unique instance in that case. But one of the things that I wanted to touch on for really, I guess, the body dysmorphic disorder, as well as, kind of tying in the anorexia nervosa, I've seen a newer perspective from the standpoint that these patients, I'm seeing a spike in stimulant abuse as a result or a desire to reduce appetite. So, people that are increasing their, taking their roommates Adderall, or, parents that have been stealing their child's Ritalin, because all of these medicines reduce appetite and therefore reduce intake and subsequently, less weight. So it's another kind of under the radar thing to keep an eye out for, is that stimulant abuse can bridge to some of these restrictive patterns and desires to look a certain way, such as in BDD.
And it just goes to show, William, and thanks for that information, because it, like always, your show is shedding light into the darkness on some of these topics. And it goes to show how there's a bunch of variables involved. It's not just one thing leads to the next and one thing leads to the next. When we're talking about humans, there's a bunch of variables involved. Something as simple as someone beginning to experiment with stimulants such as Adderall, Ritalin, can start lead to loss of appetite, which in turn can all of a sudden become something even more severe, such as struggling with the symptoms of an eating disorder. But what's your experience with Prozac as far as prescribing it for those that are struggling with the symptoms of bulimia nervosa?
I think that the goal, how I, present it to a patient is that, the literature has showed us that this is the one eating disorder that when a medicine combined with the therapy, you're most likely to have the best outcome. And, what does that mean in a different way is that, patients that show compliance when taking the Prozac are thought to have more motivation and energy when it comes to, being compliant and adherent with the therapy. So they're, following up more frequently, showing more active investment in treatment, less hospitalizations is a big one. And I think the side points would be that, we're kind of talking about a lot of these disorders as, they're the only one on board, that given patient, but a lot of these eating disorders, will have comorbid major depressive disorder or generalized anxiety disorder. So part of the belief is, the gold standard of therapy for those is going to be like an SSRI such as Prozac. So you treat the depression and then they have more motivation to, get better and curb the, some of the issues going on with the eating disorder. So, like you said, in medicine, it's never just one thing. Sometimes it reads that way in the books, but clinically we see a more complicated patient, than the questions stem in some of these review books. They have, the review books kind of have things as, 18-year-old Caucasian male comes in with this, and this, but, in reality, we're seeing, far more complex patients on a daily basis than, you typically think of when you're just trying to isolate one pathology or the other.
And William, it's starting to get late, but we can't finish without talking about one topic, and I hope you're okay. One more diagnosis, if you're okay with that, and that's binge eating disorder. Yeah. And the reason why I say we're going to have to do a 2.0 on this topic, just like all the other ones, William, because there's so much information, and that's that I'm not even, yeah. And so the binge eating disorder, so for those out there, individuals with who struggling with the symptoms of binge eating disorder engage in binge eating, but do not regularly use inappropriate or unhealthy weight control behaviors such as fasting or purging to counteract the binges. Binge eating disorder is more common among individuals who are overweight or obese. So there is reason why I find this, the binge eating disorder, something that I wanted to talk about, and I'm glad we talked about it in the end, is because both of us live in the United States, William, where obesity and we even changed the body mass index to fit our criteria now. This was like a while back because society was getting a little heavier. Food was more accessible. People didn't have to go out and hunt on their own anymore. And now food's easily accessible, and binge eating, though, is a mental illness, is a mental illness. And someone that's struggling with binge eating or the symptoms of binge eating, they tend to eat a lot and eat a lot at one time. How much, and you mentioned earlier about the comorbidity involved. Now, this gets really complicated because look at all the variables we're mentioning. The increased stressors in society, the easier access to food. Trying to and combating that with eating and food in itself is something that alters the brain. It's almost like you get a high. With the better the food you taste, the higher. The more steak you eat, the more meat. If you really are a meat lover, increase your dopamine level. So all that mixed in a pot with binge eating disorder, you think that has any sort of correlation with the stressor someone's experiencing in life?
Yeah, I mean, I think, we talk about it all the time. The brain is a very powerful machine, so in one person, the stress can be dealt with by maybe a development of smoking. In other patients, it's, they deal with stress, by reading. So maybe they're a little bit more withdrawn, but they can, kind of distract their mind. But, in others, it's can be a coping mechanism with the stress will be this binge eating that you're talking about. And I think that, it's a relatively, when you look at the timeline of medicine, it's a newer diagnosis, because I felt like, maybe a lot of these patients were kind of grouped into the bulimia at one point, kind of, inaccurately, so to speak. So, I think of binge eating as you have these two major criteria that they need to meet, and it's both. So they're eating more food in a short period of time than an average individual would eat. So it's a little bit vague. So that's one. And then paired with that is a sense of lack of self-control for that compulsory eating. So they're eating a lot and they don't have control over that. So you notice that kind of keeps weight out of it. So as a consequence, a lot of these patients are overweight, but I think more importantly is that you can have somebody that is normal weight that has binge eating.
And William, this is a part where I'm diverting to you. I'm sorry about that so much in this part, because now I'm curious as an individual. What's the difference between someone that's fasting and binge eating? And that's where the fasting came up earlier, and I was thinking about it, and I think that's good for the audience to clarify. What's the difference between fasting and binge eating? Because to me, I don't really see. You said the weight is a consequence of it. So just because someone's obese, that doesn't mean. And thank you for clarifying that, because maybe I presented the information in the wrong way. That just because someone's overweight or obese, that's just a consequence of the binge eating. It doesn't mean if someone's obese or overweight that they're struggling with the symptoms of binge eating. That doesn't mean that they don't meet the criteria, but it's just a consequence. But what about the fasting and binge eating? What's the difference there?
So I think that the biggest thing, let's say we're interviewing a patient, we're trying to delineate, is this, your typical fast, or is this, binge eating? So I think the second point that I mentioned about the generalized lack, the thought where you lack control of this behavior, keep in mind that fasting is kind of just the flip side of that. It is very fine-tuned control, where you say, I'm not going to eat for 23 hours, and from 7 p.m. to 8 p.m., I will have, as much food as I want. That is control. That is not lack of control. So, for example, they specify some of these binge eating episodes. You need to meet, without making it too complicated, you have to meet very specific things to make it binge eating. Some of those, let me think here, so eating until uncomfortably full. So it's kind of like, depending on holidays you celebrate. So maybe, kind of like a Thanksgiving meal, 3 or 4 or 5 times a week. So you can imagine the uncomfort there. eating more rapidly. That's one that I think is forgotten about. So these patients are getting through a plate of food, before, you've gotten, halfway through your first, half of the steak, something like that. And the other thing I'll end with this, from my standpoint, is that they eat alone because they feel embarrassed about how much or how quickly they eat. So you can find out a lot about, what kind of company are they eating in. Oh, I always eat by myself. That's a huge, I don't want to say it's a, one thing or the other, but it should be a reason that as a provider, you ask follow-up questions. So I can kind of leave it at that.
So thanks so much for William for clarifying that. And I definitely took down notes for myself on that aspect, because that's important. That's important to know for myself. So William, I wanted to touch on social media, but I think we should leave that for the 2.0 version,
Sure.
because that's a whole kind of worms that if we open up, we're really going to have to dissect, and the role social media has on these eating disorders and people falling into the paradigms and whatnot. So William, thanks so much, my friend, for coming on this podcast. I know that you spent all day in the hospital and you had a situation over there today. And I was there in the field today out there. And thanks so much, man, for taking time and coming here and talking to the audience about eating disorders and all the other times you've been on, man.
Yeah, well, as always, man, it's my pleasure, and thanks for including me in tonight's podcast. Looking forward to, getting into a second part of this one. I mean, it just goes to show as we start talking about, one thing or the other, and there's so many different directions that you can take it, So, sure you have a lot more to share, and I'll be happy to be part of the second version of this.
Thanks, William. And good night, world. Thanks for listening in.
All right, take care.